session, which is Research in Global Health. So this session will consider how research informs our understanding of health issues that transcend national boundaries, as well as global health inequalities globally. The speakers will outline some of the key components of global health research and the importance of equitable and ethical participation in research, as well as presenting examples of innovative, inspiring research and approaches to research. So Prof. Hutchinson will introduce the speakers, and the speakers will each give their presentations, and then we'll have questions. So Prof. Hutchinson, I'm going to call you Hutch, because I know everybody does, is Professor of Neurosurgery. He's NIHR Research Professor and Head of the Division of Academic Neurosurgery within the Department of Clinical Neurosciences at the University of Cambridge. He's leading the NIHR Global Health Research Group on acquired brain and spine injury. He's also honorary consultant neurosurgeon at Cambridge University Hospitals, and he's director of clinical studies here at Robinson College. And it's thanks to Hutch that we're hosting the conference here at Robinson College today. So Hutch, I'm going to hand over to you. Thank you.
Thanks very much, Evelyn, and thanks for arranging yet another fantastic global health conference, and we look forward to the rest of the day. So it's my pleasure to introduce the first session, which is going to be on research, and we have four fantastic speakers. The first of whom is Professor Charlie Whiffin. Charlie is Professor of Nursing at the University of Derby and one of the outstanding academic nurses in the United Kingdom. Charlie's very modest about her achievements, but she's done a tremendous amount both within the UK and globally, and she leads the Qualitative Research Initiative and the community engagement of the Acquired Brain and Spine Injury Research Group. So without further ado, Charlie's going to talk about working with communities to advance research in acquired brain and spine injuries. Thanks, Charlie.
Okay, thank you for that introduction. So, as Hutch said, I'm a Professor of Nursing at the University of Derby. I'm a qualitative researcher, and I'm leading for community engagement and involvement in our group, the acquired NIHR Global Health Group on acquired brain and spine injuries. Most of the presentation today is really showcasing the work of others, not myself. We held a webinar yesterday on CEI in our programme of research. So I really wanted to talk about the work of all of our collaborators. So first of all, just a bit of a background on our group. So we were, the first iteration was in 2017. We were the Global Health Group on neurotrauma. And then since then, we developed into the Global Health Group on acquired brain and spine injuries. And this is us at our launch event. We've had a much bigger remit and working with more collaborators from low and middle income countries. And you can see the main aim of the group is to working to understand brain and spine injury care worldwide, generate and implement innovation, and build capacity in global healthcare workforces. So for those of you who don't know, I just thought I'd just provide a little bit of context for the conditions that we research. So conditions of the brain and spine affect 1 in 3 people worldwide. It is a global public health concern. They are the reason for the majority of death and disability. And what we know is those in low and middle income countries are disproportionately affected by trauma, mostly because of the increased rate of things like road traffic collisions, but also mass casualty events from conflict and from climate change. We also know that many people in low and middle income countries have limited or variable access to tertiary care and particular neurosurgery. And quite often the health systems that are available are poorly integrated. I'll talk a little bit about some work that's been done on pre-hospital care. So what happens, therefore, is we have a significant long-term societal and economic burden for acquired brain and spine injuries. And if you think about the rate of brain and spine injuries in the younger population, lots of people are unable to return to work, and that creates a huge economic burden in this population and also in families, which is my particular interest area. I don't think you can see that very well. But this slide really just shows the 4 areas that we work on in our group. So we have mapping care, understanding care, generating and implementing innovation, and also capacity building. And really the approaches to community engagement and involvement cross over all of our themes. So I'll talk a little bit about what community engagement involvement is. I think you probably all know, but just a short definition there: it's a process of working collaboratively with groups of people who are affiliated by geographic proximity, special interests, or similar situations with respect to issues affecting their well-being. In the UK, we call it PPI, and that's something I'm particularly passionate about in my own research that I do here in the UK. So our vision for CEI across our group really reflects the vision of the NIHR, essentially that all our global neurosurgical research is undertaken in collaboration with communities that are most affected by the research outcomes. And ultimately what that does is it fosters an inclusive, community-driven programme of research. So, like I said in the introduction, I really wanted to showcase not my own work, but the work of others. We had our webinar yesterday, so a lot of what I'll talk about is the presentations taken from yesterday. So the first picture up here, that's actually Ola out in Uganda with the team leading a CEI workshop on SMS-based technology and how we might be able to use that to advance follow-up. So 3 of the case studies that I wanted to talk about are formal approaches to working with communities. So I'm really excited by the work that's going on, spearheaded really by Dr. Almas Katak in Northwest General Hospital. They have an amazing programme of CEI. Really, when we first started working together, they were already working with communities, but it wasn't a strategic approach. It wasn't formalised. They knew it was important. They did lots of really great work, but now they have a really well-attended CEI board, so a community advisory board, and now they're much more strategic about working with different community groups. They do everything from supporting researchers to co-designing patient information leaflets. They're doing patient videos and podcasts, and like I say, they just have a really inspiring programme of community engagement initiatives at Northwest. Dr. Ebenezer Tursit from Addis Ababa also talked about his community advisory board, which has been informing his work in neural tube defects and their trials, and working with communities to understand how to improve their research methodology. And then Professor Rubiano and his team talked about the importance of working with local communities to inform the TBI guidelines. So a lot of the work that they've been doing has been about stratifying guidelines for local resources, because most guidelines are developed in high-income countries, and they've been working on how to, like I say, stratify guidelines to be more appropriate for an ELMIC context. And one of the take-home messages that I had from their presentation was the statement that people are experts, and I think that's really important to remember. That when we're working to research, you have to remember that the people with these conditions are the experts, and they need to be telling us what's important, what are the priorities, and how to better inform and design our research. So a few case studies on engagement initiatives. So I always quite often think about CEI as slightly 2 different things. So community involvement to inform research, but then also community engagement. And I think what's really good is about getting out to communities, disseminating our research in one respect, but also working with communities to disseminate that. But what we need to be working on are more public health messaging. We just can't cope with the burden of disease. So actually what we need to be doing is taking research into public health initiatives. So obviously you can imagine that a lot of the work that we do in the ABSI group is about promoting things like helmet use, seatbelt use. So Anil Kumar is doing some amazing work in India promoting the use of helmets for pillion riders. So they've made great strides in advocating for the use of helmets for the drivers, but they're still carrying pillion riders, including their children, without helmets. So we were talking actually yesterday about potentially low-cost innovation to solve some of those problems, about how to actually wear a helmet in very hot countries. And then Dr. Franklin Boo, he's a physiotherapist, And again, what's striking about his work is thinking about the lack of neurorehabilitation. So lots of people are being discharged from hospital without any kind of follow-up and rehabilitation. So he's doing great work in Cameroon about advancing neurorehabilitation. He's also working on a pilot project to take to raise awareness about traumatic brain injuries, and in that pilot program he will be working with mentors who have had a brain injury themselves to deliver some of that public health messaging. And then from the African Brainchild and the team in South Africa, they've had an amazing initiative about Be Quick to Click car seat drive, because a lot of children are being injured in car accidents, and a lot of that's because they're down to the fact that they don't have car seats, and they've been giving car seats away. And then Ursula Rolwick also talked yesterday about some of the work that they've been doing to inspire the next generation of neuroscientists, taking their work into schools, educating children, getting them inspired in this particular field, love of the brain, but also through those still advocating for public health messaging around the use of seatbelts to reduce the number of children who are injured in accidents. And then I also wanted to talk a little bit about, again, the amazing work being spearheaded by Professor Tariq Khan at Northwest General Hospital in Pakistan. And they're really working on TBI as a notifiable condition. This is a really essential area, and it's something that we really need to understand the full burden of TBI. And they've just hosted the G4 Alliance about a week or so ago. And what was really nice to see in that work, when obviously very influential people are in that room, having people with lived experience of traumatic brain injury talking about their own experiences of brain injury, the impacts on them and the importance of making TBI a notifiable condition. And actually hearing from people with lived experience, it makes that message so much more impactful. So the next steps for us with CEI and in our ABSI group, and also starting to look to the future, we've been working on a review of CEI in ABSI research, which is published. So Raman is working on that, leading on that, and we're supporting that with Kate Jack from University Hospitals of Nottingham and Shobin Dangra, who's here. But essentially what we're doing in that is trying to understand a little bit more about what works for who and in what context, and that's really important because the context is really different across all the different countries and all the different studies. We're looking forward to the next funding round and thinking much more strategically about how to embed CEI. So we will work on the results of the realist review and understanding of CEI to inform that strategy. We will look for much more local leadership for CEI and joint mentorship programs. There'll be a much higher emphasis on co-design in those projects, and importantly, we'll have some ring-fence funding for CEI opportunities. So reflections on all of that work. Really that working with communities in low middle income countries offers numerous advantages for improving our research. Really importantly, it ensures relevance and contextual fit. It shifts power from extraction to participation, and I think that power shift is really important to work with rather than on. And fostering those meaningful and importantly long-term relationships between researchers and communities. And then ultimately it improves policy, impact and knowledge exchange, and therefore drives real world change. And that's it.
Great, thanks very much, Charlie. So we're going to save all the questions for the end, and it's a great pleasure to introduce our second speaker, who's Dr. Michael Bath. Michael is a general surgery registrar with an academic interest, particularly in global surgery. He's a PhD student in the International Health Systems Group in Engineering. He works with Tom Bashford, and he's recently been awarded a very prestigious fellowship from the Royal College of Surgeons. So, Michael, thank you.
Thank you so much for the opportunity to speak today. As just said, my name's Mike. I'm a general surgery registrar from London, but also a PhD student in our International Health Systems Group, based in the Department of Engineering here in Cambridge. And the talk here today, I'm trying to say, can we, within global trauma care, how can we get high quality research come out so we can get some meaningful outcomes? Professor Whiffin highlighted a lot of this, but just to recap, the current global burden of trauma, it's a very important topic. Around 10% of all deaths that occur worldwide have some association due to trauma. Massive impacts that occur in the adolescent and young adults. And unfortunately, it is those resource poor areas that, whilst they do have those highest rates of trauma, they often have the worst outcomes. And then we know that if we can improve the outcomes in those settings, we could save around 2 million lives per year. So there's a huge scope. And this diagram here really highlights the issues that we're facing. On the left is the number of trauma-related deaths around the world proportionately, and on the right is the number of doctors in these regions. But that number of doctors could represent anything. I've used doctors here because that was an easy metric to identify, but that could be anything from availability of pre-hospital care to blood transfusion services to rehabilitation. And it's that whole system that we need to try and improve. And trauma care in itself should really be viewed as a complex system. You have lots of factors that are interplaying in the patient's care, lots of different people involved from the time of injury through to that rehabilitation process. And why I'm in the Department of Engineering myself is it's trying to take on that systems approach to try and unpick this a bit further. And so how can you try and map trauma care? How can you try and better understand this complexity within it? And there's benefits of doing quantitative and benefits of doing qualitative research. However, we know that to get those big hitting stats, to get people to listen, often you do need those numbers, that quantitative research. However, the heterogeneity that often occurs in these trauma patients' journey means that fitting these numbers to such heterogeneity is really difficult. It's that square peg in a round hole. And so while storytelling can give us a richer picture of what's going on in these trauma pathways, there's also issues that occur with storytelling. The trauma patients, there might be the psychological impact of recounting their stories. Accessing these regions to get one-to-one interactions with the participants can be challenging. So it's trying to find that balance, and certainly we found that starting at least with that quantitative research is one way to approach this. Sorry for the squeamish amongst you, I should have put a warning before putting that picture on. But so one way that we've done it is picking a single point pathology to try and reduce some of that noise in the complexity of trauma care. And we've used the trauma laparotomy as a marker of this. A trauma laparotomy, that's the big cut down the middle of the tummy that you need if you have any traumatic abdominal injury. And it's a key procedure within trauma care. And even in low resource settings, there's high morbidity and mortality rates associated. But importantly, lots of people need to come together to get that trauma laparotomy patient through. So we're using a single point to try and map this. Previous work that sort of touched on this area within global surgical spheres. The Global Surgery Group in Birmingham have done amazing work, but they mainly focus on elective general surgical care and elective abdominal care. The group that we've worked with closely in the UK have done previous work on trauma laparotomy, but that was, as I said, basically in the UK. And then Professor Hutchinson's group in Addis had recently published the GENOS study in neurotrauma. And so that's led us to the point of the study which we're currently running, which is the GOLD trauma study, the global outcomes after laparotomy for trauma. And so we're trying to better understand, using the trauma laparotomy as a marker of trauma care, to understand who are the patients, what injuries do they have, how do they get to hospital, what the management that they've got, and what are their outcomes. And one of two slides that I'm most proud of is, this is the first one. This is who we've been supported by in working this project. So it's not just the groups based in Cambridge, but we've got groups based in Europe, we've got groups based in Latin America, we've got groups based in Sub-Saharan Africa, who all have been supporting this project to get it to where it is today. Just to briefly summarise the study, I won't go into too much of the details, I promise, but we are running at the moment a multi-centre observational study, and we're looking at anyone who undergoes a trauma laparotomy following any type of injury. And we're collecting that data from the time of injury through to what happens in hospital and what their post-operative outcomes are. And one of the really take-home messages here, we piloted this work before launching it, not just in the UK, but we piloted it in Uganda as well, to make sure the protocol that we had, the data points that we were collecting, were as tight as possible. There was no leeway. We're really trying to make sure that noise that I talked about is as clear, is as reduced as possible, so we have as clear-cut data points, and all the data points are feasible to collect. We have got ethical approval from the University of Cambridge, but again, we've worked with our collaborators to make sure that they get local approval from their centres as well. I said I won't go through all the protocol points, and I certainly won't, but this is just an example of some of the strengths of this study. Easy to identify time points. We found that any centre in the world is able to collect the time points of injury, but you can unpick so much information from these time points. From the time of injury to the time they got to hospital, when the operation occurred, when the operation started, and when they were discharged. And there'll be so much nuance that we can further unpick with substance qualitative research from these time points. The study itself as well, we've translated the protocol into multiple languages, so French, Spanish, Mandarin, Russian, Hindi, there's a couple Italian, and there's a couple of others I can't think of, but just again to try and maximise collaborator support. And then the next slide is the second picture that I'm most proud of, and this is our current recruiting site. So we've really got a fantastic spread across the world, really trying to better understand global trauma care. And as of last week, we've got over 1,000 patients recruited, over 190 hospitals involved, and across 45 countries. And as of yesterday, that's now 47 countries. Within that, there were supposed to be little flags next to that today. I don't know why those letters have appeared, but the regions that we have involved, also just to highlight, there are areas that are in active conflict or in humanitarian crises, which you have been able to collect data from. So Ukraine, Sudan, Yemen, Palestine, Somalia, DRC and Haiti. And my gratitude for all the collaborators involved, but particularly from these areas, that they've been able to contribute to this study. It's a bit of my reflections, what have been the challenges that we face, certainly in the lower resource settings, to collect this data. Most people can probably imagine there's been issues with communication, lack of internet or 2 or 3G signal, and so often we're trying to be as flexible as possible how people can recruit this data. We've made it to adapt in how we've collected this data as well. Often we have very stringent processes in Cambridge saying, you need to fill out this form and do this. As I said, these guys don't have internet or sort of routine access to internet, so that's become challenging. I mentioned already the heterogeneous patient journeys that have been involved as well, that have been quite challenging to unpick, but that's really been addressed by having a really tight data set that we know that all these areas will be able to quote. Finally, one thing that took me by surprise, or probably my naivety in this, is even some of those basic resources in collecting data, lack of paper, for example, has been a barrier for some of these centres to collect data. And my final slide is just some quotes from collaborators that I've got over the last few months. Sorry, it's a bit smaller text, but just to read out. And I feel very humbled here presenting this work and be able to read these out, because it sort of highlights the sort of issues that many of our collaborators have had, but they've been able to participate. So first one is a collaborator from Sudan who emailed saying, due to the ongoing war, unfortunately its effect on our town in which our hospital is located. Because of this, we're unfortunately not able to add any further cases. We couldn't access the hospital and were unable to communicate with the study team due to loss of internet. We hope that our small contribution was of value to your study. And then the second one was a hospital in sub-Saharan Africa, again, just trying to highlight that complexity and heterogeneity in patient journeys. The patient was technically discharged on the 5th, but they stayed on the ward until the 9th due to financial constraints. So trying to match that up with your quantitative data can also prove challenging. So in summary, it is possible to collect high quality quantitative data, but we're probably going to unpick more questions than we do answers as a result, and that's where the qualitative aspect will come really into its strength. I've really been sure throughout the study that our data points are feasible for everyone to collect, so we're not having any missing data, and it's all good for everyone to be involved in. And as I said, and I showed earlier, having multiple groups to support the study, to support the dissemination of the study has been fantastic. Thank you very much.
Thank you, Mike. Really clear presentation. So our next speaker is going to be online, but live and not recorded. So that's Dr. Assefa Tesfaye, who is a clean-cut clinical lead in Lifebox and works at St. Peter's Hospital in Addis, Ababa. I hope the link is going to work. Assefa, can you hear us?
Can you guys hear me?
Yes, very clearly. Can you hear us?
Yes, I can.
Perfect.
A bit of a tricky connection here. I'm gonna try and go ahead.
The connection is good. So thank you so much for talking to us, and we look forward to hearing your presentation.
Perfect. Let me share my presentation. Thank you very much for the warm introduction. So my name is Dr. Assefa. I work in Ethiopia at St. Peter's Specialized Hospital, and I'll be giving a small talk on some of the lessons learned from the clean-cut project that we did in Ethiopia, but also elsewhere in the country. To just give you a little bit of a highlight, clean-cut is an adaptive multimodal quality improvement project that tries to improve on the PRP infection prevention practices. The time duration for that is like a 6 months project. And we basically start by looking at the PRP infection prevention practices within the hospitals by looking at some of the process mappings that they have, and then also combining that with some of the quantitative data that we try to collect. And we put those together and try to meet with the surgical team within the facilities and come up with exchange ideas and generate improvement plans on the subsequent months. And there are 6 PRP infection prevention standards that are of focus here: appropriate skin preparation, antibiotic prophylaxis, sterile surgical field, instrument sterility, gauze counting, and the utilization of the virtual surgical safety checklist. And there are some tracking measures that we use, such as the 6 critical infection prevention measures that I mentioned, but also surgical site infection as a primary outcome, and hospital lengths of stay, reoperations, mortality, and other infectious complications as secondary outcomes that we've been following. And to just give you a little bit of a highlight into the development of the project, we started it back in 2015, where we piloted it in 5 hospitals in Ethiopia, and then in 2017 we developed the first playbook, which was a stepwise approach to the implementation of the clean-cut project. And then we also did a qualitative study into how what are some of the barriers and facilitators to the implementation, and then taking that, we developed the strategies and refined it, and then implemented it in 7 hospitals as a second cohort. And following that, it has been expanded to other African, but also other Asian countries. And then following that, since 2021, we have been developing it to fit into some of the very common surgical practices that we know, such as cesarean section and long bone fractures. And to look at some of the data that we have from the publications, this is the very first one from the pilot study, which was implemented in 5 hospitals. And you can see that the red line in the red plot is the very first baseline data that we had, and it was a low performance. And after the implementation, you can see that we were able to improve all the 6 PRP infection prevention matrices, and also that impacted the surgical site infection rate, which was reduced by 35%. And most importantly, there was a 46% relative risk reduction in surgical site infection with those hospitals that showed a higher compliance with those 6 infection prevention compliance matrices. So this was a huge learning for us, and then that's what we took to the next cohort of hospitals, where we had 7 hospitals. And as you can see on the graph, there was a compliance in the infection prevention practices over time. and that impacted the surgical site infection outcome, which was decreased from a 23.2% to 17.4% post-intervention, which was statistically significant. And we also saw that there was a relative risk reduction of surgical site infection of 34%, which was a very similar number to the previous 5 hospitals, which were the pilots. And this was a great learning for us as we tried to roll out the project to the other countries that we have been implementing the project. And CleanCut to date has been implemented in 46 facilities. Some of the countries here you can see are Ethiopia, Liberia, and others. And as I mentioned earlier, it has been modified to fit into some of the very common surgical practices such as cleft and cesarean section. One of the publications that we have in 2024 is from JAMA. It's on CleanCut for cesarean section, which was implemented in 10 hospitals. And you can see that we used a stepwise approach to this implementation. And you can see there was 5 clusters. And what we saw was a trend, which was an improvement in infection prevention compliance metrics over time. And one of the things that we also noticed was that following the intervention packages, which included trainings and also process mapping activities, we saw that changes in compliance were most pronounced right after those things were implemented in the facilities. And this was actually continued through the entire duration of the project implementation. And so that you can see that the intervention phase was sustained with the change that we saw in the earlier phase. And the CleanCut for long bone fracture, which is the last thing that I'm going to talk about, was implemented in Queen Elizabeth Central Hospital in Malawi with the collaboration of Johnson & Johnson. And what we saw in this facility was at the very baseline, we saw that the 6 pair of infection prevention practices were in the low side. And as you can see, except the 2, which were the ghost counting and antibiotic prophylactic administration, were actually good performances initially as well, but the remaining had a poor performance and we were able to improve on those. And as a conclusion, we can see that CleanCut has helped improve the surgical safety in the low-income countries that we mentioned, and we believe that the program is needed to increase beneficiaries and a synchronization of implementation with different organizations, such as what we're doing in Sierra Leone with a collaboration with Mercy Ships, as well as MSSI and SPECT, is of utmost importance. And thank you for your time, and more publications can be found on the Lifebox website. Thank you.
Thank you, Assefa. Really clear talk and really, really important initiative. Are you able to stay on for the discussion after the next speaker?
Yes, I'll be here.
Great, thank you so much. So our fourth and final presentation is from Dr. Alype Rwamatwara, who's going to present from Ethiopia and Rwanda. Dr. Rwamatwara is an antibiotic timeout fellow, the Rwanda Clean Cut Project, and works as a GP in Kigali. Alype, can you hear us okay?
Yeah, I can hear you well. Can you hear me?
Yeah, really good. Thank you so much. And you're able to... Last time we did this, the presentations were from Cambridge, and the link from Africa is so much better. So fingers crossed it continues. Thank you.
So, good morning and good afternoon, everyone. I'm Alype. I'm a clinician from Rwanda, and I'm a fellow at Lifebox. And I will be presenting on this topic called optimizing surgical antibiotic prophylaxis in low resource settings. But before we go into this presentation, I would like to acknowledge that we've just concluded World Antimicrobial Resistance Awareness Week. And Lifebox, through this antibiotic timeout program, is working to advocate for antibiotic stewardship within surgical care, as this is an area where inappropriate use of antibiotics can contribute to antimicrobial resistance. So Wait, what is happening? So antimicrobial resistance is a top 10 public health issue where 1 in 6 antibiotic prescription worldwide is given for surgical postoperative prophylaxis, with the highest burden in low-resource settings where surgical site infection rates are high and infection prevention practices are poor. So from our observation made across 19 hospitals in 5 resource-limited countries where CleanCut has been implemented, we noted antibiotic overprescription postoperatively in patients underwent clean and clean-contaminated procedures where 28% of them received postoperative prophylaxis more than 24 hours, which is not recommended by WHO. Also, this prolonged course of antibiotics did not result into decreased rate of surgical site infection, but contributed to extended hospital stay and to antibiotic resistance. So, as a result of that, we decided to develop antibiotic timeout program to strengthen antibiotic stewardship practices within the surgical community. So we piloted this program at one facility in Ethiopia, and the focus was those patients underwent clean and clean-contaminated procedures and has been hospitalized in the ward postoperatively. And over the period of 6 months, we enrolled 606 patients, with 25% of them included during the baseline phase, and the rest included over the intervention phase. With this intervention, we saw a 20% decrease in prolonged postoperative antibiotic prophylaxis, which also trended with decrease in length of hospital stay, as shown on the graph in the right side of your screen. So the main limitations of antibiotic timeout program in Ethiopia was that we did not address the underlying issue of poor infection prevention practices. Therefore, in Rwanda, we incorporated antibiotic timeout into CleanCut in 4 sites, aiming to enhance infection prevention and antibiotic stewardship through training sessions, surgical antibiotic stewardship guideline development, while monitoring the antibiotic prescription practices during the operative periods to promote adherence to the approved guidelines. Also, patients are monitored for surgical site infections through 30 days post-operative follow-ups. The preliminary results from the first 2 facilities in Rwanda shows significant trend towards improving antibiotic stewardship at one facility, while the other hospital already had strong stewardship starting from the baseline. And the overall observation from CleanCut implementation in Rwanda is that by addressing gaps in infection prevention practices, facilitate engagement in strengthening antibiotic stewardship practices. This is because we emphasize on the link between poor infection prevention practices and antibiotics overprescription postoperatively. However, in facilities with strong antibiotic stewardship, for example, this one represented by blue dotted line, it gives the team the time to focus on other areas of improvement, as Assefa has talked about in the previous presentation. So to conclude, antibiotic timeout offers a scalable solution to strengthen antibiotic stewardship in low-resource settings and engaging hospital staff to build capacity for innovative health intervention can be key to fostering resilient healthcare systems. So that was all from my end. Thank you for your kind attention.